So good morning, everyone, and thank you so much for joining us today for this webinar. My name is Kate Stenyam. I think I've met almost all of you that are on the line, and I'm a manager with the Delta Region Community Health Systems Development Program. If you could, as you're joining, I know you can see the chat, but so that we know everybody who is in attendance here today, if you could please put your name, your title and organization in the chat box, that would be fantastic. So today our webinar topic is the Delta Doctors Program. And as you saw as you're joining in, the event today is being recorded. The link to the recording is going to be posted on our website, like all of our webinars, and it'll be sent out in an email following the completion of today's webinar. So this webinar is a part of the Delta Region Community Health Systems Development Program. And I am with the National Rural Health Resource Center, and the center is the technical assistance provider for this program. Just a couple quick logistics. I think you all know that your audio is muted by default to avoid background noise and feedback. We ask that you remain muted unless you have a question. So to unmute your line, you just select the microphone icon in the lower left corner of your screen. And if you dialed in by phone, you can press *6 to unmute your line. You can also communicate through that chat box, which is located at the bottom ribbon in the middle of your screen. I would encourage you to, we don't want this to be super formal. So anytime you have a question, please feel free to pop that into the chat box. We will have a Q&A for our speakers sometime at the end, but please feel free to pop questions into the chat box or come off mute anytime you might have a question. So if you want to go to the next slide, Tabitha. Thank you. So again, I'm with the National Rural Health Resource Center, and we're a nonprofit organization. We're dedicated to sustaining and improving healthcare in rural communities. And we are the technical assistance provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program, which we'll just call the Delta Program, is funded by the Federal Office of Rural Health Policy, and that is in collaboration with the Delta Regional Authority. The center, the National Rural Health Resource Center, is committed to diversity, equity, inclusion, and anti-racism, and building a culture within our center and within the world where difference is valued. If you would like to learn more about our commitment, you can please check out our website or contact any of our staff individually. So now I have the pleasure to introduce today's session. Again, this is the Delta Regional Authority's Delta Doctors Program, and it aims to provide non-domestic, U.S.-trained primary care and specialist physicians to healthcare facilities in Delta Regional Authority counties, many of which are, of course, designated as health professional shortage areas. These physicians are required to work for a minimum of 3 years, and many of them are retained long-term. So today, our speakers are going to talk about the Delta Doctors Program and how facilities in the DRA region can engage with the program in order to obtain the services of qualified physicians. So while I guess I'm introducing our speakers, Tabitha is going to launch a couple polling questions. Please take a quick minute to fill out those polling questions when they pop onto your screen or when they're ready, because it's really important for our program and it's a way for us to get some program evaluation information. Thank you, Tabitha. Okay, so today's speakers are Christina Wooden and Barry Walker. Christina Wooden joined the Delta Regional Authority in March of 2016, and she oversees the DRA Health Programs and Partnership Programs, including Delta Doctors, Innovative Readiness Training, and our program, the Delta Program. Barry Walker is the principal attorney of Walker Immigration Law Firm in Tupelo, Mississippi. He has been a practicing attorney since 1975. His practice is concentrated in employment-based immigration with an emphasis in physician immigration and hospital and clinic representation. I'm going to be quiet now and let our speakers take it over.
Thank you, Kate. I am Christina Wooden with Delta Regional Authority. We were created in 2000 and we invest in human infrastructure and critical infrastructure. Our Delta Doctors Program is part of our human infrastructure programming. So a little bit about the Delta region. Our footprint includes 252 counties and parishes across 8 states. 234 are deemed distressed, and over 9 million residents reside within our footprint. 1 in 5 people in the Delta live in poverty, and 116 counties within our footprint are deemed as persistent poverty areas. So the redder the area that's highlighted, the greater the level of poverty. And of course, we cover those 7 states plus the Alabama Black Belt. Go ahead, thank you. Health outcomes in the Delta. This is probably no surprise to you all. If you look at the obesity, diabetes, and physical inactivity rate within our region, we approximately 91%, as you see on the screen, of counties and parishes in our region are in health professional shortage areas, which is very important. You'll see in the upcoming slides. Next slide. So the purpose of the Delta Doctors Program, we invest in human infrastructure, and that means that we want our workforce healthy. And that is the main reason why DRA participates in the J-1 visa waiver programs. We want to ensure that we have a healthy workforce. So the purpose of the program is, of course, to increase access to quality care and to provide medical services to health professional shortage areas and medically underserved areas. I'll give an overview of the Delta Doctors Program, and then Mr. Walker will get into the nuts and bolts of the programming. Can you go back 1 slide for me? So in order to participate in DRA's J-1 visa waiver program, the Delta Doctors Program, there are a few commitments that we require, or that's required for, well, any physician. The facility must show proof of a 45-day recruitment period. That means the healthcare facilities must show that, hey, we tried to recruit an American physician, we put forth our best faith effort, and no qualified applicants were obtained. The physician must serve at a facility within our footprint, and that facility must be located in a health professional shortage area or a medically underserved area. And the physician must provide direct patient care for 160 hours per month or 40 hours per week. And the physician must agree to serve patients regardless of their ability to pay. So these are some of our numbers. And excuse the sniffling, I've had a nosebleed, so it looks like it's trying to take over again. For FY 2022, we have, I'm gonna have to put my screen, I'm gonna have to stop the video and continue. My apologies. For FY 2022, as you can see, we provided 70 J-1 visa recommendations to, actually, go ahead, Mr. Walker, if you could take over my presentation. I am going to have to step away.
Okay.
From I've got a pretty bad issue going on here. I believe you can walk through. Thank you so much.
Sure. I think it's helpful to stop a moment and reflect and discuss a little bit about the presence of foreign medical graduates in the United States. And it's helpful to understand how physicians are educated and trained. Of course, we know they go to medical school and they obtain a Doctor of Medicine degree. We also have in the United States, for instance, osteopathic schools. And osteopathic schools are really important. There are more and more of these that are being developed and opened around the country. An osteopathic physician has training that's a little different from a medical doctor, but they are equal in qualification to a medical doctor. For instance, an osteopath has eligibility to move on to a medical residency, which is the next step in training of a physician. There are different types of medical residencies. There's internal medicine, family medicine, pediatrics, psychiatry. And of course, there are surgical residencies. And then physicians can go on and train in further in a more specialized way in advanced fellowships. So you might have a cardiovascular physician, a hematologist, a cancer doctor, orthopedics, many other types of subspecialties, nephrology, urology. And then you have foreign medical graduates who want to come to the United States and engage in these advanced training programs. They would like to come and train as internal medicine physicians, family medicine physicians. Many of them like to go on to advanced fellowships. And many of those foreign physicians are already trained, educated, and some of them have years of experience in their home countries. Well, there's a legal framework which addresses the entry of foreign physicians to the United States to engage in training in the United States. And those physicians, for the most part, come with a special type of visa called a J-1 exchange visitor visa. And that visa has a feature which requires that doctor, once they come to the United States, they do their advanced training in the United States. Once they complete that, they're required to return to their home country for 2 years before they can advance or come back to the United States and obtain a work visa to live and work in the United States. Now, not all of these physicians have an intention to settle in the United States. Many of them obtain their training here and they return back to their home countries and live and work there. But if they train in the United States and they complete their training, they're required by law to return to their home country for 2 years. However, there's a very well thought out feature in the law that says that if that physician commits to work in the United States for 3 years in an underserved area, either a health professional shortage area or a medically underserved area, then that 2-year foreign residence requirement will be waived. And that is the central mechanism of the Delta Doctors program. So what's happening is that instead of returning to their home country for 2 years, they commit to work for a facility in a shortage area. Now, you have several different programs in the United States that have standing under the law to make waiver recommendations. And the Delta Regional Authority is just one of those programs, but it has a very well-developed and a very well-functioning program that recommends foreign doctors for the waivers, and then they ultimately can end up in a Delta Regional county, working in the county for at least a minimum of 3 years. And then there are also mechanisms to hopefully incentivize them to remain long-term. There are other agencies that have standing to make waiver recommendations. All of the 50 states have standing to make waiver recommendations, but they can only recommend 30 waivers per year for their state, and that's called the Conrad 30 program, and that was named after Senator Kent Conrad, formerly of North Dakota. But there's also the U.S. Department of Health and Human Services that has jurisdiction throughout the United States, but their program is only primary care, whereas the Delta Regional program, for instance, recommends and places primary care physicians as well as subspecialty physicians. Because if you are a facility in the Delta region, you know that if you're a FQHC, for instance, you know that you need family medicine doctors, you need pediatricians, you need internal medicine physicians, and those facilities rely heavily on these J1 waiver programs. But if you're a large hospital in the Delta, you also know that you have difficulty attracting a subspecialty physician, a surgeon or a cardiologist or a hematologist. And the DRA and the J1 waiver program helps to locate and incentivize these specialty physicians to come to the Delta for at least a minimum of 3 years. So we know that about 1 in 5 physicians currently in the United States were born in and graduated from medical schools in foreign countries. We'll call them IMGs or international medical graduates. There are about over 200,000 of these physicians working in the United States. In 2022, about 7,864 IMGs entered postgraduate training in the United States. In other words, they matched, you may have heard that term before, they matched to residency programs in the United States. Those physicians are competing against American graduates for these slots in these various training programs around the country. Next slide, please.
Barry, can I just pop in with a quick question?
Indeed, yes.
Okay, so just make sure I'm, understanding. So the providers, they do medical school in their country. They have to do residency, their training here in the United States. They're required to go back home for 2 years unless they commit to providing services here in a shortage area. And then you had noted that that can be a variety for primary care or different specialties.
Correct.
So you had noted there's a cap. Do they break up the numbers, like saying that so many of these waivers are going to be given to primary care slots, so many are going to be given to this specialty or that specialty?
That's a good question. Now, that kind of goes to, for instance, the Conrad programs, which are the various state programs, the 50, actually the 54, because the Marshall Islands and the Virgin Islands and the territories have actual Conrad programs. But each one of those programs is given the discretion to design their program to fit their state. So some of those programs will have a preference for primary care, for instance, and they'll open up their program each year and they'll accept applications, and they'll know that they want to fill their primary care slots first. So you may have some states that devote almost their entire 30 slots, for instance, to primary care. But it really depends on a state by state basis. And in earlier times, there was a huge preference for primary care. But then the HHS entered the arena, and they have a 50 state program, and they only do primary care. So they really do the lion's share of primary care placements, and that has kind of freed up the states then to take on more applications for subspecialty physicians. So now, by contrast, the DRA recommends both. And it's just in each individual application, the facility has a requirement. They have the burden of showing that they have a need for that particular physician. They may be or they are in a shortage area, but they, for instance, if they're trying to place a cardiologist, they're going to have to, do a census of how many cardiologists there are in the county and in the practice area, and they have to show that they've, tried to recruit that physician or subspecialty for some time. They have to prove up the individual need for each one of these placements.
Okay, and then just one more follow-up question on that. So for the slots, you said that's really defined by the states, and of course, the health professional shortage areas, those can be urban or rural. Is there a number of slots that are designated specifically for rural? Or is it just at the discretion of whoever just is putting in for the?
There's no preference. I don't know of any of the programs that have a preference necessarily. Well, no, I want to take that back. I think there are some of the Conrad programs who have a preference for rural placements. For the most part, the vast majority of these are in rural areas, although in some locations you have shortage areas in urban areas. I know Jackson, Mississippi has shortage areas. Manhattan, but amazingly, the Bronx, Brooklyn, parts of Chicago, they have shortage areas, and they have placements of physicians. And then some of these Conrad programs do have preferences for rural placements over non-rural.
Thank you.
It's important to note, people will wonder, well, I'm seeing this physician here, or my parent or my family member is seeing a physician from Nepal or the Philippines or the UK or Australia. How do I know that this doctor is as qualified as a US doctor? Well, there is a scheme, a regulatory scheme that really goes to a considerable distance to make sure that the foreign physicians that come to the United States are indeed as well qualified as an American physician. For one thing, they do have to pass before they can enter a clinical practice. They have to pass the United States medical licensing exam. That's the same licensing exam that American physicians have to take. It's a 3-part examination. They also have to obtain, before they can enter a training program, they have to obtain a certification from the Educational Commission on Foreign Medical Graduates, the ECFMG. They have to show that they have English language proficiency, and they have to pass a clinical skills examination. Then they have to go on and compete with U.S. graduates to match to a residency or fellowship in the United States. And then most states require that the physician, before they can enter full practice, they must have completed a residency or 3-year fellowship in order to obtain a state license. So you can be pretty, confident that a foreign medical graduate has passed muster and have been deemed to be as qualified as a U.S. physician. And then there are steps that they have to go through to move from a training status to a status where they can actually practice medicine in the U.S. For the J1s, they have to either go home or they have to get that waiver of the 2-year foreign residence requirement. The waiver application starts with one of the agencies that has standing to make a waiver recommendation, whether that's one of the Conrad 30 programs or the Delta Regional Authority, or the most recent entrant into the program is the Southeast Crescent Regional Commission, which is a really well-developed commission, covers the southeastern U.S., parts of, even Mississippi, Alabama, all the entire state of Florida, Georgia, and the Carolinas. And the Southeastern Crescent's program was patterned closely after the DRA's program. It's currently headed by Bevan Hunter, who was previously with the DRA. Once a agency makes a recommendation, then that recommendation passes on to the U.S. Department of State and then on to the U.S. Citizenship and Immigration Service, and they have the legal authority, the USCIS has the legal authority to grant the waiver that says to the physician, you're not going to have to go home for 2 years. You can remain in the United States for 3 years and work in Mississippi or Alabama, Tennessee, or one of the states from which the waiver came. And then at that point, the physician's immigration status is changed by the Immigration Service on application from a J-1 exchange visitor to an H-1B so that they can begin employment. The H-1B status is a 6-year status. It's not a permanent status. It's a 6-year status. Now that process that I just described to you, the waiver, the change of status, my law practice, I've been an immigration attorney for about 33 years, and since the early 90s, I've been engaged in physician practice, and now I spend over 80% of my time working in the physician immigration field, and the vast majority of that is dedicated to the J-1 waiver. So this is something that I kind of live and breathe on a daily basis. So let's move to the next slide, please. Of course, my clients, typically, I'm initially contacted by a facility. Now, all of our facilities have recruiting efforts that are continuous. It's a struggle. You know, if you're a facility in Mississippi, Alabama, Tennessee, Louisiana, it's a struggle, I'm sure that many of you know, to attract and recruit qualified physicians to come, especially to rural areas. But my clients initially are FQHCs, rural health clinics, primary care clinics, the few county hospitals that we have. You know, in Mississippi, we don't have very many freestanding county hospitals anymore. When I started practicing this area in the early 90s, we had hospitals that were freestanding, unaffiliated hospitals owned and operated by counties. Well, the economics made that impossible. And especially in our state, we're one of the states that have not expanded Medicaid under the Affordable Care Act. We recently went through a session of the legislature where for the first time it was at least seriously debated in both houses of the legislature. Both houses had potential programs on the floor. They couldn't come to a consensus, and the governor said what the heck, he was going to veto it anyway if it came to his desk. But I touch on that because that in part is responsible for the demise of our county hospitals. Now, if you go to Illinois, even in the southern counties of Illinois that are in the DRA, you'll see county hospitals, freestanding, viable county hospitals that serve their local communities. We represent urban hospitals, hospitals that have full complements of subspecialty physicians, surgeons, cancer, cardiovascular programs. We also represent some academic medical centers, for-profit hospitals, as well as freestanding physician groups. Now, all of these entities have standing to request J-1 waivers And all of these hospitals and facilities depend to some extent on the availability of foreign medical graduates. Here's just a list of all the different types of medical specialties that can come to the Delta region, sponsored by the DRA. Family med, pediatrics, internal medicine, gastroenterology, hematology, nephrology, rheumatology, cardiology, infectious disease, and pulmonary critical care. You know, one component of the DRA program and the J1 waiver program is that the physician and the facility must agree to treat everyone regardless of ability to pay. So in reading this list and seeing the rheumatology specialty brings something to mind, a story from a few years ago. I was talking to a rheumatologist, J1. He was at a hospital in South Mississippi, and he said he was just flooded with patients. That some of his patients drove over 100 miles to come see him, and these are people with rheumatoid arthritis and that type of thing. And what they were telling him, his patients, is that they could not get an appointment with a rheumatologist in their local community because no one would treat an uninsured patient. They wouldn't treat a Medicaid patient. So the only physician that they could get an appointment with was a J1, a former J1 who received a waiver, who was in his 3-year period during which he was under an obligation to treat everyone regardless of ability to pay. So that's just a little, vignette that shows you how important this program is to get medical care to people in these rural parts of the country. Again, some of the features of the program: the physician and the hospital or the employer must pledge that the physician will work in a specified underserved area or areas. The work area has to be clearly defined, really to prevent abuse, because there are some parties who will hire a J1 physician and they'll try to this doesn't happen much anymore, but in the old days, they would hire the doc to work here, but they would want him to take shifts outside the area in a location maybe where they could make more money. That's almost non-existent anymore. But in the program, the work site is specifically identified so that the physician will be sure to be dedicating his services to the area that has the need. Again, both parties must pledge to provide services.
So it's 100% of their time, correct? Has to be there. Like you guys were going over the hour commitments before. So it is 100% of that 40 hours a week or 160 hours a month.
That's correct. They have to devote their full-time practice of medicine to that defined area. And they have to pledge to provide services to all patients regardless of ability to pay. Uninsured patients below 200% of the poverty level must be charged on the basis of a sliding fee scale. Now, again, that becomes really important in a state like Mississippi, by example, where we have a large group of our population who are working poor. And these are people who are working. They make too much money to qualify for Medicaid, but they're not in a job that provides medical insurance. So in a statistical measure, their family household is going to fall in many cases below 200% of the poverty level. And if you are a facility that's employing a J1 physician, you're going to charge that patient at a sliding fee scale based on their income. Many facilities have charity provisions that are as favorable and maybe even more favorable than some of these sliding fee scale provisions. But the idea is to get the medical care to the people who need it. The physician must agree to accept Medicaid, Medicare, and this is especially important for indigent patients who need subspecialty treatment, hematology, rheumatology, endocrinology. Okay, next slide, please.
Mr. Walker, we have a question in the chat. Is there a similar program for nurses?
Frankly, I'm not sure. Now, there are probably other folks on this phone who might know better than I do. I know for physicians, there are loan forgiveness programs, you know, for commitment to underserved areas. I frankly, I just don't know whether that type of provision pertains to nurses or not. I suspect that there may be, but someone else would have to speak to that. Sorry. I use Mississippi. We practice beyond Mississippi and in all of the DRA states. I'm using some Mississippi statistics because they're pretty representative. All of our 82 counties are designated either in whole or in part as medically underserved areas, according to the Health Resources and Services Administration. The DRA program is a very well developed and functioning program that serves the indigent populations in the, I should say, 8 DRA states. And it's an example of good government, I would say. The mechanism that's in the law that says to the doctor who trains in the United States, if you don't want to immediately go home for 2 years, we'll let you stay, but you got to commit to 3 years in an underserved area. That's a very simple mechanism. It was devised back in the 80s, and it works very well, and it certainly works to the benefit, I think, in my experience, in our DRA states. Let's see, that may be, is there another slide or is that it? Yeah, okay. So I'm able to answer any questions that you may have.
Thank you so much, Mr. Walker. This is Christina Wooden with DRA. I am back online. My apologies for that minor snafu earlier, but I am available to answer any questions you might have of me.
Yes, please pop in any questions into chat. Mute, and as you're thinking of questions too, Tabitha will pull up a post polling for everyone to fill out, please. Yes, and Blake Kramer, thanks for the question about the similar program for nurses. Our team will do some research, see if we can find any more information on that.
You know, just as an aside, just a little anecdote. Back, I think it was in 2004, the DRA co-chairman at that time was a fellow by the name of Pete Johnson. And Pete was a longtime Mississippi politician and public servant. And he was the head of the DRA. And he was one of the people who had the original idea for the Delta Doctors program. And I was involved, along with some other attorneys, in advising the DRA on the development of their program. And we made a couple of trips to Clarksville and had meetings with Chairman Johnston. But he told us a story as to what sort of inspired him to get involved in initiating this program. And he talked about a fishing trip that he was on overnight over on the Mississippi River. And he developed suddenly just a severe illness. It turned out to be hepatitis. And he ended up over in the emergency room in Cleveland, Mississippi. And he was treated by a foreign doctor. And he says that's the first time in his life he was ever treated by a foreign doctor. But the fellows sat by his side all through the night and got him stabilized. And Pete was convinced that the man saved his life. And that was sort of the, impetus for him to go on and start this program. So I always thought that was an inspiring story at the time.
Has either of you ever seen an OB or a GYN do this program?
Yes,
Yes.
yes.
And I will add to Mr. Walker's story, a more recent story. My son is epileptic, and we could not, for about 6 months, he was having seizures, could not figure out what the problem was. And one night we had to rush him to the ER in Sykeston, Missouri. We live in a pretty rural area down here in Missouri. And there was a physician there on a J1 visa. And I tell you, she in 24 hours had a diagnosis. So this is just a testament to how the J1 visa waiver program works in real time. And it is life-changing.
Yeah, those are powerful stories. And I want to tell everyone here today too, if you need more information or want more information on this program, please reach out to Christina Wooden to help you navigate how to go through all of this. And also Alexis Foster on our staff, who wasn't able to be here today, but she works with Christina on this, and Barry too. So we can provide more support to any of our sites that are looking into this. So please don't hesitate to reach out. Did any more questions come through the chat, Tabitha?
No, that's it.
Okay. Thank you. Well, I want to thank our speakers for joining us today. And we hope to see all of you back here next week at the same time, next Tuesday at the same time. We'll be doing a webinar next Tuesday on AmeriCorps. And that webinar is going to provide an overview of AmeriCorps, which is the only federal agency dedicated to the National Health Service Corps. So thank you.
Thanks
Hope
for
to see you all
inviting
back
me.
here next Tuesday.
Thanks so much.
Thank you.
Thank you all.
Bye-bye.
Bye.
Bye-bye.